Good evening, Dr. Vijay. Thanks for a kind invitation. Let me congratulate the previous speakers for an excellent presentation. Actually, my job has been made very easy, but I'll like to summarize the 5 abstracts that I have been given. How do you use it? And actually, many of the questions has already been asked by Dr. Vijay, and I think I'll be answering some of the questions, but based on the data that is available. So let I hope probably everybody will enjoy this next 15 to 20 minutes of my presentation. My slide, yeah. So these are the 5 abstracts that I will be discussing. The last 5 abstracts that I have been given. Let me start from the most important abstract, I think, of the 5 abstracts, and I will be going like a story from there. This is the most practice-defining abstract according to me. This was a 5-year updated analysis of Keynote 024 study. Everybody remember that it was a comparison with first-line Pembro versus platinum-based chemo in those with a TPS score of more than 50. This was presented in ESMO 2020. I will not go into detail, but let us remember following important points that we have to remember. When you look into the studies, 66% of the patients from the chemotherapy arm had in fact taken immuno-oncology drugs. This is more important. That is why even after giving these 66% patient immuno-oncology, the survival was so less. So the first take-home message is use your IO drugs early. Now, this is in a nutshell Keynote 024 data. Now, when you look into it, when somebody asks me, why should I use the immunotherapy? Just remember these two things. In 2000, if somebody would have told me that at 5 years, 31.9% patient will be surviving, I will be thinking that he is joking. And now we have a data which says that in these subset of patients, 31.9% patient will be surviving for 5 years. And more importantly, 26.3 months of overall survival, probably one of the biggest. A very impressive response rate of 46.9. Now my question comes to you is, what about the 70% of the patients? So at present also we have improved our survival, but still it is 30% 5 years at best. So what about the 70% also? And that is what I will be discussing in the next few slides. The third important take-home message is this Keynote 024 gave me is, I can re-challenge my patient with immuno drugs provided they have responded. So if you see, out of the patient who responded, took treatment for 2 years, stopped and again relapsed, 12 of the patient, if they were given, 10 patients had either a PR or a stable disease. So again, if I have a patient who has responded to ICI, and if I have stopped it and they relapse, I can reuse it, and 10 of the 12. Again, you remember 80% of the patient will have a partial response or a stable disease. This was a third take-home message. This was a question which was being asked, and I will be telling you the data. Is there a role of chemotherapy in patient with PD-L1 of more than 50%? And the answer is role of chemotherapy is not clear, and only time will tell us. But I'll be telling you the data. Now, when you look into Keynote 024, 26.3 months, and when you look into Keynote 189, please remember it was chemo plus IO. The OS in those with a TPS of more than 50 was 27.7. So more or less the same. Then comes the question, how do you decide? Do we have a data to say this? So the answer is yes. This was presented in this ESMO 2021 by Solans Peter. This was a real life data of close to 24,000 patients, those who were given treatment, and they took out 520 patients, which was given chemo, immunomono or a combination. Now, what they observed was no improvement or chemotherapy is not needed in PD-L1 more than 50, except for one subset, and that is why you have to have a take-home message. If I have a patient on a Monday morning who is a never smoker, I will, even if the PD-L1 is more than 50%, I will not use a single agent IO. So for one point that you have to remember is that even if your PD-L1 is more than 50, if you are a non-smoker, probably you should add on a chemotherapy. The other valid indication that this trial suggested is if you are a never smoker, a high burden of disease, perhaps females, perhaps a low TMB, because this has not been tested with a single agent IO. Probably these are the subset in my practice where even if the PD-L1 is more than 50, I'll think of giving my chemo IO combination, not as a single agent IO. Now, when you talk about Nivo-IP data in this subset, actually there is no data of PD-L1 more than 50 in Nivo-IP, but at best what you get is 33%. Again, a less impressive rate of 40 to 45% 3-year survival when we saw the other data. So from me, Nivo-Ipi not a combination to be used in PDL1 of more than 50. Now comes the important question again, and that is the basis of my second thing. I'll be joining the two in the last. Whether can I improve my outcome by adding a ipilimumab to pembrolizumab in the subset of patients with PDL1 more than 50? We know that IO is equal to chemo IO. So by adding a anti-CTLA, am I able to improve, or when can I improve the option? So that was the keynote 598 which was presented. So the same subset of patients with a PDL1 of more than 50, we add a CTLA, but this is not with Nivo, it is with Pembro. Now what you observe is there is absolutely no benefit in terms of median OS, 21.4 versus 21.9, 8.2 versus 8.4, and 45.4 versus 45.4. So the fourth take-home message is no added benefit when you use the anti-CTLA. Probably you don't require any more immune stimulation. The problem is there is more toxicity. Just look into the mass. 35 versus 19, 27 versus 13, 6 versus 3. So you are increasing your toxicity by twice without any meaningful improvement in your response rate, PFS, and OS. So the fifth take-home message is no advantage of adding ipilimumab to pembrolizumab in patient with PDL1 of more than 50. It just adds side effect without any effectiveness. Now comes again my question that I asked on the first. Is there any way we can improve the outcome in patient with PDL1 of more than 50? Chemo does not improve, anti-CTLA does not improve. Now comes the most important. The answer is yes, maybe. Please go back to your December ESMO Immuno-Oncology Conference. This was the final updated analysis of CITYSCAPE study, which included anti-TIGIT antibody tiragolumab. Just look into the data that I am telling. From 4.1, please, this is the only subset where this drug will work really. In those with a TPS of more than 50, the 4.1, it increases to 60.6. So 4 times increase in PFS by adding an anti-TIGIT antibody. Please remember, this is the final updated analysis. At 2 years, 78% of the patients are surviving. So for me, yes, from that 30, I might reach to 40 and 50 by using this anti-TIGIT. 16 months have never been reached in any of the studies as a PFS, let alone the OS. And at 2 years, you see 78.2% of patients are surviving. So for me, the take-home message from abstract 1 and 2 is keynote 024 data is historic. 31.9% 5-year survival for metastatic non-small cell lung cancer is incredible, unheard in 2000. Treatment is well tolerated and retreatment possible with reasonable response and stable disease. Please remember, retreatment is possible. And future is bright in this subset of patients with more than 50 with the addition of novel molecules. We have an updated data presented last year, CITYSCAPE, which shows 16.2 months PFS and 2-year survival of more around 80%, and which is amazing. And slowly we are increasing that voltage ladder performance. Now comes my question number 2. In patient with PDL1 1 to 49, look, please remember, chemo IO versus IO in more than 50, no advantage. Now I am comparing the same in 1 to 49. So in patient with PDL1 1 to 49%, is there an advantage of adding chemo to IO? Why not a single agent IO? So that was presented in this ESCO 2021, and I will try and be summarizing what was there. Now, when you look into it, 8 trials were taken. 2 trials had compared IO versus chemo, and the other 6 trials had compared IO chemo versus chemo. Please remember, this is a comparison between IO chemo versus IO, and the original trial had compared between chemo in the other arm, but this meta-analysis is comparing IO in the other arm. So that is the main difference. So I have put in this. Please remember, the pivotal trial mentioned above had originally compared IO chemo versus chemo. Now, when you look into the PFS, statistically significant improvement in PFS, 4.2 to 7.7, and more importantly, the icing on the cake is nearly 7 months improvement when you use chemo to IO, and this was also statistically significant. So 32% reduction in the risk of death. But again, these are all the meta-analysis, and you have to consider it as hypothesis generating. The other subset that I will like you to concentrate is, what if in which subset I should not give my IO chemo, or probably IO may be sufficient. So that is it. In 2 subsets you have to remember. More than 75 years, probably there is not much added benefit of adding chemo to IO. So in more than 75, yes, I think still the debate is on whether you should give a single agent IO even in 1 to 49, or give only a single chemo, or give but not IO plus chemo. And the second subset that I want you to discuss is never smoker. Please remember, don't give your single agent IO in a never smoker. Probably, even if it is more than 50, 1 to 50, in a never smoker, probably single agent IO is not the way. So because the quantum of difference in this subset is the maximum in chemo IO versus IO arm. So the take home message from abstract number 3 is, what is the best treatment in PDL1 1 to 49 patient as on Monday? So please remember, no IO single, not chemo, but combination of IO chemo, 32% reduction in the risk of death, although this was a meta-analysis and exploratory. But be cautious in patient more than 75 years, because here the benefit was not there. And please think twice before giving single agent IO in a never smoker. Let me ask you one more question, and that is the basis of the fourth abstract. In poor risk subset like liver metastasis, how do immunocombo, that is ABCP, perform? And the second question is, in driver mutation positive, like that is the EGFR mutation, where single agent immuno does not work good. You have seen the responses are very poor when you see. How does this combo work? So this was presented in two parts, ESCO 2018 and ESCO 2020, and it was the basis of subset analysis in one EGFR, and second is the baseline liver metastasis. So when you look into it, although the numbers are not big, but 14% of the patient had liver metastasis, and around 10% of the patient in the entire population had EGFR mutation in it. So when you look into the overall updated analysis, when you look into it, around 41% reduction in the risk of progression overall, and around 22% reduction in the risk of death when you use ABCP1, any of the combinations. So overall, a positive study. Now, when I look into liver metastasis, please remember the hazard ratio. I'll go back to slide. The hazard ratio was 0.78. And I look into the slide with liver met, this hazard ratio is 0.54. So what does it suggest is probably the quantum of benefit in the poor risk subset is better than the entire population. So yes, one question was asked, where do I think of giving a ABCP? Yes, in liver mets, it is a thing. The second point of contention is, remember your IM Braves data. That was the first line HCC data in where you had 19 months. That also included the same two drugs, atezo-bev, but this was with chemotherapy. So what is being suggested is the pathophysiology remains the same. A hypoxia inducement, increase angiogenesis, and increase VEGF activity. And by combining the two, probably the pathophysiology in liver mets of the patient with lung cancer remains the same. So probably for me, the small tilt will be for ABCP combination. Let me discuss the second subset, EGFR and ALK. The first analysis again showed that the hazard ratio is 0.54. Again, the benefit is better than the entire population. Now, when you look into the updated analysis which was presented, this quantum of benefit again continues to remain very impressive with the hazard ratio of 0.60 with an absolute survival of close to 2.5 years. Probably this is the best survival in the second line or further settings. 2.5 years is better than the first line. And that is why if I have been given this drug and I have all the resources post EGFR failure, I may think of giving this combination with such a impressive data. We know that BEV works very well in EGFR subset along with TKI. You have remember your NEJ studies 009 and 026. Now let me do a cross trial comparison. We have only two data of patient with liver mets. This is ABCP and this is I have taken out from Keynote 189. Now compare the two. Again, slightly better quantum of benefit when you see ABCP, but again, I will be careful. This has been only by me. This has not been conferred in any of the conference, but yes, the more or less the data or the quantum of benefit remains more or less the same. So how to choose? So any of the two combos seems okay, but a slight tilt to ABCP in view of a very impressive data of atezo-bev in primary HCC, which carries the same pathophysiology. So once you go to liver, the pathology remains dependent on the hypoxia factor, and anti-VEGF normalizes the vasculature. So probably a slightly better data, but again, it is for you to decide. I am giving my opinion. So the take-home message from abstract number 4 was, in clinical practice, I may keep ABCP as one of the options for my patient with definitely liver mets. Probably the quantum of benefit is the best among this subset, even better than the Keynote 189. Again, this is cost trial. And of course, second line in EGFR mutant with a OS of 29.4 months, which is probably unheard of in the second line. Of course, you need to rule out your T790M because if I have given a first generation TKI, I will be giving a osimertinib. The last abstract that I will be discussing, which was very well spoken by Dr. Anjana, was a poster presentation in ESMO 2021. I'll try to summarize it in 3 slides because this is a way you should remember. On a Monday morning, should I think of doing my early circulating DNA and how does it help in my treatment making? And that is an analysis from the MYSTIC study. Now, when you look into MYSTIC study, basically a study which compared durvalumab versus tremelimumab compared to platinum-based chemotherapy. This was a negative study. Please remember, we should not discuss much, but yes, in one subset, which was an exploratory analysis in blood TMB more than 20, there was an improvement in overall survival, but that was not the primary endpoint, so probably not much discussion. But the main discussion is circulating tumor DNA at baseline and week 6. When Madam was discovering BEP2 means it was at week 6. So we do this estimation on day 1, give 1 cycle, and then see the reduction in the burden of disease. Now, first take-home message is if you see the baseline ctDNA, if your variant allelic fraction is more than median or above median, if it is below median, your survival is better. So if your tumor burden on day 1 is lesser, indirectly it tells you that your survival will be better. So the first take-home message from the study was baseline ctDNA level prognostical. Please remember, prognostically associated with survival outcome in metastatic non-small cell lung cancer, irrespective whether you give chemo or immuno, because the second point is different from that. So if your burden is higher, irrespective of whatever you give, your survival is poor. Now at week 6, please remember, they said molecular responder means more than 50% decrease in baseline VF are considered as responder. So if your response is at week 6, if your response was more than 50%, please see your durvalumab 28.4, 27.9 versus 10.4. So in immunotherapy, if on week 6 you see your patients, your load coming down by 50% or more, you are supposed to survive for more than 2 years against chemo, where this effect was not seen. Probably I don't know the reason, but yes. So if your chemotherapy responder, they respond early, and if they respond when, your survival would be wrong enough. So the second take-home message from the was molecular responses based on early ctDNA dynamics appear to translate into longer overall survival with immunotherapy, but not with chemo. And molecular responder distinguish long-term survival in both patients with or without. So probably this is a futuristic. I am really excited. So do it on 0 day, do it at week 6. If you see your 50% VAF coming down, probably your survival will be more than 2 years. So for me, it is a futuristic approach. This concept of ctDNA is still evolving. The best application, according to me, that was spoken one line by Dr. Anjana. At week 6, if I see my VAF not reducing by more than 50 or 50, I think I should think of adding on my therapy, escalating it, or replacing it. So the best application of this study in clinical practice is to rapidly assess response or resistant to immunotherapy at week 6. So probably the treatment can be modified. You can escalate it, you can intensify it, your treatment accordingly. So that was all from it. I thank you all. At the end of the day, all these things have meant to improve your 3 goals: your quality of life, your progression-free survival, and what we say holy grail is the overall survival. I thank you all for a patient.